main inflammatory bowel diseases are Crohn's disease and ulcerative colitis. There are a number of differences between the two. Notably, with Crohn's disease being able to affect any segment of the alimentary canal from the mouth to the anus, and it also affects all the layers of the intestinal wall, meaning it's a transmural disease. So the inflammation extends deeper than in ulcerative colitis and can also involve neighboring structures and organs. As a consequence, in Crohn's disease, we can observe strictures and fistulas. These are pathological connections between the intestinal lumen and neighboring organs. The two cardinal symptoms of Crohn's disease are abdominal pain and diarrhea. On the other hand, the ulcerative colitis only affects the colon and usually progresses continuously from the rectum upwards to the more proximal segments of the colon. Inflammation is limited to the mucosa and submucosa, or we don't see fistulas. The strictures are much less common, but patients with ulcerative colitis run a rather high risk of developing colorectal cancer than patients with Crohn's disease. Moving on to epidemiology, a ballpark estimate for developed countries is that both diseases together affect just about 1% of the population. Here you can see a map of a recent-ish systematic review of prevalence of these diseases from population-based studies. So red means a higher prevalence, so there's more of the disease. And we can see on the top panel for Crohn's disease, the redder nations are further to the north, what we tend to call developed countries, while nations in South America and Africa are acknowledging relative scarcity of data for those countries, have a lower prevalence of inflammatory bowel diseases. The same trends can also be observed on the lower panel, where the situation is depicted for ulcerative colitis. As with many, if not all, immune-mediated diseases, inflammatory bowel diseases are the consequence of a complex interplay of genetic and environmental factors. By way of illustrations, you can observe some of the genetic factors in the panel on the left-hand side of the slide. At the very left, we have very, very rare genetic mutations, which leads to monogenic IBD. So one gene is mutated, and it leads to the certain development of inflammatory bowel disease in a given patient. These patients are very rare and tend to fall ill as very young children already. So these are two rare examples, the mutations in IL-10 and XIAP. On the other hand, we have a number, as we move further to the right hand side of the slide, a number of polymorphisms in different loci, mainly related to genes regulating immune response and autophagy, which have a smaller, yet still non-negligible impact on the development of inflammatory bowel disease. But taken together, we now, this is a rough estimate, getting bigger every year, we now know around 250 loci associated with IBD, and mutations in these loci explain or account for roughly 10 to 15% of IBD we see in daily clinical practice. On the right-hand side of the slide, we see a number of environmental factors. Please note, of course, that these are associations from epidemiological studies, and of course, we cannot speak of causality with absolute certainty here, but you may see some emerging patterns, many of the environmental potential risk factors being associated to what could summarily be called the hygiene hypothesis, the way we in the Western sort of developed countries live in sanitized and clean environments. And the other aspect being diet. What is a universal observation from epidemiological studies is that currently, while the incidence, that means the number of new cases of IBD per year, has stabilized in Western countries, it continues to grow in the developing countries, and there is robust evidence that moving from sort of a country in development to a developed country, adopting the habits of the new country, their diet, increases the risk of developing IBD. This is a hot area of research trying to pick out dietary triggers of IBD. And finally, a very important risk factor, which is interesting because of its divergent impact on ulcerative colitis and Crohn's disease, respectively, that's smoking. So patients who smoke are less likely to develop ulcerative colitis, but more likely to develop Crohn's disease. And the clinical course of Crohn's disease in smokers is usually worse. So we've now seen the symptoms these diseases cause and what we think are the triggers of disease. Now we can move on to what we're trying to achieve for our patients. What are our treatment goals? In the top panel, you can see summarized for clinicians a kind of a Bible for IBD. These are the STRIDE recommendations, which delineate the treatment goals in inflammatory bowel disease. To put it simply, we need to alleviate the patient's symptoms and at the same time achieve healing of the intestinal mucosa. So just improving symptoms is not enough. You can see a very bad case of Crohn's disease in the extreme left image and a bad case of ulcerative colitis in the middle image. It's important, very important to note that you want to achieve normalization of the intestinal mucosa on top of symptom improvement, because persistent endoscopic inflammation, so the inflammation of the mucosa, which we can observe with our endoscope during procedures, is the driver of complications further downstream, which I've already alluded to. So narrowings in Crohn's disease, fistulas, developing the necessity for surgery, intestinal resections in Crohn's disease, and the risk of colorectal cancer in ulcerative colitis. So now we've seen what we're trying to achieve in inflammatory bowel disease. How are we going to achieve this? This is a short overview of the approval timelines of advanced therapies from IBD, beginning at the first drug, infliximab, approved for Crohn's disease right at the beginning of the millennium, and somewhat later for ulcerative colitis. You can see a quite high number of drugs belonging to different therapeutic classes, different mechanisms of action. We have monoclonal antibodies, such as antibodies against the tumor necrosis factor alpha, antibodies against integrins, antibodies against interleukins, whether non-selective or well, less selective or completely selective to IL-23. While on the other hand, we have small molecules, inhibitors of Janus kinases, and modulators of sphingosine 1-phosphate receptors. So we have a rather large number of drugs available. This was not always the case. As you can see, it took more than 10 years to move beyond anti-TNF drugs in IBD. And one could say that we are now almost spoiled for choice. So well, we're on the verge of maybe not curing IBD, but treating it very effectively. This is unfortunately not quite the case. Here is an illustration of some of the phase 3 trials. These are endoscopic remission rates. Of course, the attentive listener to this presentation would be quick to know that definitions changed somewhat through the years, but we can see that nearly not all the patients receiving active drug also achieve endoscopic remission. And if we add to this that, of course, despite being a stringent endpoint, also endoscopic remission is thrown to the placebo response, which is in the region of 5 to 10%. You'd see that these rates are even lower. So on the optimistic side, we're moving around 30%, and this has been called therapeutic ceiling in IBD, conveniently placed at 30% for reasons I've illustrated above. And this was a review paper where the authors enumerated a number of potential areas where improvements could have been made, either scientific advances or clinical advances in terms of how care should be provided to patients, how they should be monitored. And for the purposes of this introductory talk, we'll just have a quick look at how pharmacometrics and therapeutic drug monitoring could help us in certain situations with inflammatory bowel disease. So to give a better understanding to the entire audience, I'm sure many of you are already familiar with these concepts, and it may be old news for you, is the comparison of monoclonal antibodies to small molecules. As I've alluded to previously, we have two large groups of drugs available for IBD. So it's either the monoclonals, very large molecules administered either intravenously or subcutaneously, depending on the route of administration. The bioavailability and the speed of absorption, of course, vary. They're mainly confined to the intravascular compartment, and being proteins, they're also immunogenic, which is important, as we'll see later, because the patient's own immune systems can develop antibodies to these effective drugs, thereby diminishing their efficacy. While on the other hand, the small molecules, the synthetic drugs, they have a smaller molecular weight. They're administered orally, or the bioavailability is high, and they're mainly, not all of them, but mainly metabolized by liver cytochromes or through conjugation, and they have an accordingly shorter half-life compared to monoclonal antibodies. So we've seen immunogenicity. Another important factor for monoclonals is the rather substantial inter-individual variability in pharmacokinetics between patients. So here we see simulations for infliximab in a number of patients, and the shaded gray area shows the bottom part is the 5th percentile and the upper part is the 95th percentile. And we see that the range of concentrations to capture 90% of our patients is rather broad, and it would be it would make clinical sense. It would be a good idea to be able to identify proactively which patients are going to be at the top end, for which we're conceivably less worried, and patients at the bottom end, which run the very realistic risk of simply not being exposed to enough drug for it to work effectively. So we've mentioned immunogenicity. This problem for anti-TNF drugs, this is mainly for anti-TNF drugs, was tackled a number of years ago in the landmark SONIC trial, the results of which you can see here. So after discovering that infliximab was immunogenic and that antibodies to infliximab could diminish its efficacy, It was tested whether adding an immunosuppressant, in this case azathioprine, could perhaps improve treatment outcomes by diminishing the risk of immunogenicity, and this was indeed the case. Patients receiving both infliximab and azathioprine did better in terms of endoscopy and in terms of symptoms than patients receiving either drug in monotherapy. On the other hand, looking at therapeutic drug monitoring, this of course could be an entire talk in its own right. So I'll just give you some high-level thoughts. So measuring drug concentrations can help guide therapy, inform decisions about dosing, either the dosage itself or the interval of dosing, and it can both lead to improved long-term treatment outcomes, as indicated by the Kaplan-Meier curves on the left, where patients receiving proactive measurements of concentrations and clinicians acting upon them. These patients doing better on the long run than patients under the standard of care, and dosing this intensification for infliximab was more cost effective when a TDM-based algorithm was used, bearing in mind both the concentrations and the potential presence of anti-drug antibodies, and doing treatment in this intensification based on this algorithm rather than just increasing it blindly was cost effective. Of course, TDM is no silver bullet. You've seen how I mainly mentioned TNF antagonists. The evidence is less clear, and there's even more debate between gastroenterologists on how we should be using, if at all, TDM for these newer drugs. Then there is debate for TNF antagonists. Classically, we've focused on trough concentrations, which was, well, if nothing else, it was convenient for intravenously administered monoclonals. The patients came to the clinic, to the hospital, to the infusion unit for their new dosage. Just before receiving the new dose, their serum concentrations were at their lowest expectedly, and it was a convenient time to draw the serum sample. Of course, it would also be said that this is it makes sense because trough concentrations capture all the pharmacokinetic processes, but this is not necessarily the case, and perhaps additional metrics of exposure to drugs should be explored and perhaps give us a better idea on how to improve outcomes for our patients. Admittedly, among gastroenterologists, as much as we like measuring concentrations and pretending to have a clue on what to do with them, our approaches are, well, if being benign, we could call them empirical, being stricter, or you could say blindfolded or ignorant. Basically, it's they're based on our feelings and impressions, and perhaps using model-informed precision dosing in daily clinical practice could be a way forward, at least for some of the drugs we have. And finally, we have two very special subpopulations in both diseases. In Crohn's disease, we have perianal fistulizing Crohn's disease. This is a particular form where we've mentioned fistulae. These patients have debilitating symptoms of incontinence and constant seepage from their rectum. It's been shown that these patients need a much higher concentration of the drug for the fistulas to heal more effectively. And on the other hand, we have acute severe ulcerative colitis, a potentially life-threatening form of acute exacerbation of ulcerative colitis, where patients also probably need more drug to avoid surgery and enjoy nice treatment outcomes. So this brings me to the end of my presentation, and I'm happy to pass the relay baton on to, well, via Erwin to Lisa. Thank you.
Okay, thank you, Jurij, for this very nice overview, very concise overview, very complete as well. Looking in the chat box, I don't see any questions. I think everyone is still thinking about their questions. Please, if you have them, feel free to share them in the chat box or in the question app, and we will discuss them later. For now, let me share my screen again, so I can introduce our next speaker. So after Jurij, now it's time for Lisa Schots, the next speaker. Lisa obtained her medical degree in 2018. She's currently a resident in dermatology at the Free University of Brussels in Belgium. In 2024, she will finish her PhD at the University of Ghent under supervision of Professor Ljubljana, for which she was granted a personal fellowship by the National Research Fund. And her research currently focuses on optimizing the use of biological drugs in the treatment of psoriasis. With that, I will give the floor to Lisa.
Okay, thank you, Erwin. Just to be sure you can hear me clearly?
We can hear you perfectly.
Okay, thank God. I'm sorry, so I'm combining my phone with another computer, so I hope I will manage. So I will share my screen. So I think everyone can see this one.
I can see
perfectly.
it.
Perfect. Okay, so good evening, everyone. Thank you, Erwin, for the nice introduction. So I will give you some overview about psoriasis, the skin disease, a bit about the treatment, and most importantly, briefly about how TDM has its place in the treatment management of psoriasis with the biologics. So to introduce to you, so psoriasis is a chronic inflammatory immune-mediated skin disease. It is one of the most prevalent skin diseases next to atopic dermatitis. It has different subtypes, and the most frequent subtype is a psoriasis vulgaris, or the plaque psoriasis. So it's characterized with the well-demarcated scaly red plaques, mostly on the extensor sides of the knees, the elbows, but also on the scalp. So as I said, it's very prevalent. So in Belgium, we have 3,100 patients with psoriasis and 65 million patients worldwide. So why is psoriasis important within the dermatology field? Because it is very prevalent. It's a chronic skin disease. It's a lifelong disease, and it also has an important negative psychological and social impact that impairs the quality of life of the patient, because it's very symptomatic. They experience itch, and they also experience social isolation because of the visual lesions, the scaling. So this is very important, and it's also known with comorbidities such as psoriatic arthritis. So 1/3 of the skin psoriasis patients have arthritis. Also very common other cardiovascular disorders, depression, anxiety disorders, and other immune-mediated diseases. So as I said, there are other subtypes of psoriasis. So at the left, we see the psoriasis, the cutata psoriasis that's triggered by a streptococcal infection. Then we have the flexural psoriasis under the breasts and in the genital region and under the axillary regions, and also the nail psoriasis. And nail psoriasis is an important clinical feature, or how do I say, patients with nail psoriasis have a higher risk of developing psoriatic arthritis. A bit of epidemiology very shortly. So it is equally prevalent in men and women, and it has 2 age peaks of incidence. So most patients develop psoriasis at the age around 39, and then again a second peak between 60 and 70 years old. So what are the risk factors of developing psoriasis? So Actually, in general, there is a triad of a complex interplay between genetics, or a genetic predisposition. Then we have the triggers, and then we have the connection with of course, the immunological mechanisms. So these three are in a complex interplay. So in genetic predisposed patients, triggers like smoking, certain drugs, but especially stress, bacterial, viral infections, but also smoking, alcohol, and obesity can trigger psoriasis or aggravate an existing psoriasis. And also a very important phenomenon or a trigger of psoriasis is the Koebner phenomenon. So in patients with psoriasis, when they have a trauma on the skin, for example, when they need a surgery, or they do a tattoo, or even they scratch or itch, then they can induce lesions on that site. Also very known for psoriasis that if a patient has skin lesions, they occur almost every time at the same place they have occurred at first. That's very characteristic for psoriasis. So a bit of the back to the basics, so the immunological mechanisms. So in short, in genetic predisposed patients, after a trigger, then we get the development of self or auto-antigenes and self-RNA DNA, and they will stimulate the plasmacytoid dendritic cells in the skin, and they will stimulate the myeloid dendritic cells, and they on their turn produce the key interleukin 23. And this cytokine will stimulate the T helper cells to differentiate to the T helper 17 cells, and they on their turn, they will produce also a very important cytokine in psoriasis, the interleukin 17. And this last cytokine will stimulate the keratinocytes to go in a pro-inflammatory state and proliferate, and this will end in the characteristic scaling and thickening of the skin. And then the keratinocytes on their turn, they will produce more pro-inflammatory cytokines, and they create a loop back to the immune cells, to the Th17 helper cells. So they create a loop, and it's in fact on this immunological mechanisms, as we already know from the other immune-mediated diseases like IBD, rheumatology, that we have targeted therapy with the biologics. So maybe a bit about assessment of disease severity. So it's important to know in Belgium, patients who will get approval for the reimbursement of biologics, they have to have moderate to severe psoriasis, and it's with the PASI, so it's a psoriasis area and severity index, it's a score. It's on the basis of that score and some other characteristics, they will get a reimbursement for biologics. So it's moderate to severe psoriasis. Mostly this is a score of PASI 10. The score depends on the one side on the area that is affected, and then secondly on the other side the severity of the lesions. And here we look at erythema, induration, scaling, and voila, so the patient gets a score. Again, back to the comorbidities, it's very interesting to know that the comorbidities that are associated with psoriasis, they have common immunological mechanisms. So here, this is a slide made by Rani Sunen, my colleague. So she made an overview of how the different cytokines have common connections pathways with every comorbidity in psoriasis. So we actually see psoriasis now more as a systemic disease instead of just a skin disease, and it's also treated as such. Here we see a timeline, and with this slide, I want to show you that we have come from the broad spectrum era where we treated moderate to severe psoriasis with broad immunosuppressive treatment. And as we year by year found out how psoriasis is being developed and aggravated on an immunological base, we were able to find and target very specifically the causing cytokines of psoriasis. So we also had evolution from the TNF alpha blockers, so the older biologics, and afterwards we had ustekinumab, and then after the neurobiologics, so the interleukin 17 and interleukin 23 blockers. And also interestingly, so this year in November 2023, we had the approval of reimbursement of a first TYK2 inhibitor. So it's of the group of the JAK inhibitors, the deucravacitinib. So it's very interesting because sometimes we are not able to prescribe the biologic because the patient is not severe enough according to the PASI score, but there is sufficient influence on the quality of life of the patient. So this is measured by some questionnaire, and then we are able to describe deucravacitinib. So it's a very nice one in patients who are not severe enough according to an objective score. Here, this is an overview of how the treatment armamentarium of psoriasis now also in Belgium is situated. So, of course, we have to start with the topicals, so the creams for the patients that include the corticosteroids, mostly in combination with the vitamin D derivatives. If this is not enough, or there are a lot of adverse events because of the topical treatment, or the patient is done with constantly using the creams, we can go to the light therapy. Here, the downside of it is if it's used too much, the light therapy, they have a higher risk of doing a non-melanoma or melanoma skin cancer. So that's the downside of the light therapy. It's also practically, it's very difficult because the patient has to come to the clinics or a dermatology practice for 3 times or 2 times a week for 3 months consequently. So it's a good treatment option, but practically, logically, logistically, it's not the preference of the patient. Then the next step on the treatment ladder is the conventional, so the broad immunosuppressive treatment, so methotrexate, cyclosporin, apremilast, and then at last the biologics, which we all like to prescribe, but they are expensive, so it's a difficult balance for some patients. And for some patients, it's difficult to understand why one patient can get a biologic and the other not. And in Belgium, 10% of the patient is indicated for biological treatment. So I'm not sure, I'm not going to focus too much in what TDM is, because we are all TDM researchers, experts. So as we all know, if we prescribe a treatment, there is a dose, we have an exposure in the blood, and then we have the effect of the treatment. And in psoriasis, it's the same with the biologics. So now in general, if we prescribe a biologic, it's according to a standard dosing regimen. So each biologic has its own dosing regimen. So we say it's a one-size-fits-all dosing, and we see in the real-world practice that patients clinically respond very differently. So we have at the one side, we have the excellent responders who are lesion-free for a long time. So in this subset of patients, we might think maybe they are overexposed and maybe they can have less treatment with equal response. And then on the other side, we have the suboptimal responders. And here we can see maybe they are underexposed, or maybe we are not targeting the right predominant cytokine of their own psoriasis mechanism. So here is an illustration of 2 interleukin 17 blockers, so ixekizumab and brodalumab, and interleukin 23 blocker, guselkumab, of the dosing regimen. So biologic specific and standardized. It's important to know, and I think you already know, that biologics are extremely expensive, and they actually, well, as I said, it's very nice to prescribe a biologic to a patient because you know the patient will, in most of the cases, will respond very well, but there is also a price cost. And I think for biologics in psoriasis, we don't speak a lot of the safety toxicity, because there are not a lot of safety issues related with the biologics prescribed in psoriasis, but we can talk about the financial toxicity. So here's an illustration of our expenditures in Belgium in the dermatology field in general. So, and here we can see that the first and the third place are taken by the interleukin inhibitors and the tumor necrosis factor blockers. And if we look more specifically, then the number one prescribed or the money that's spent the most is for guselkumab, and then at the third place for secukinumab. And that the budget that the dermatologists spent in Belgium for 1 year was 65 of the brutto money that was spent in dermatology at general. So this is around more than 100 million euros that's spent for prescribing the interleukin 17 and 23 and TNF alpha blockers. That's a lot of money. So if we were interested actually in if dermatologists themselves actually prescribe only by the standard dosing regimen, or maybe they already try to change the dose of a biologic. And we did a survey among our dermatologists at the Congress and also online, and that the majority of the dermatologists, they confirmed they do change dose of a biologic. And when we had a closer look and we asked, like, how do you do the dose change? Mostly it was dose escalation, and in lesser extent the dose de-escalation. And here you can see it's mostly by playing with the time interval. We also did a study at our own plus cohort in patients that were treated with interleukin 17 blockers, so ixekizumab, brodalumab, secukinumab. And here, so in our own clinic at the department here, we see that we do treat modifications, and it's mostly because of the insufficient responders. So there are the primary non-responders, the secondary non-responders. We have patients that have residual lesions, but also patients that have a flare of their psoriasis, but also psoriatic arthritis. And in a lesser extent, we have a subset of patients that are excellent responders to biologics. So those are the reasons why we changed the dosing regimen or the treatment in psoriasis. And we mostly changed our treatment with the interleukin 17 blockers by switching to another one, in or outside of the class. Secondly, we did a dose escalation that was mostly in secukinumab treated patients. And in lesser extent, we also did dose de-escalations in the excellent responders. It's also important to tell that those treatment changes, these modifications, so switch and those changes, they were done on an empiric base. So they were done by trial and error. We had no clue if we did a change that we knew, okay, this patient will respond well, or this patient, they will not respond well. So it's a kind of a blindly treatment modification. So we are looking for how can we do clinical management of the biologics in a more evidence-based, rational way. And then there comes the place of the biomarkers, TDM, and even patient profiling. So, and we, as a Ghent group, have been doing research in TDM as well. I'm going to skip this one. Maybe also important. So we did not only do the exposure response studies in the novel biologics, but we also did some pilot studies for sampling techniques. So if there are any questions about that, please do at the end of the presentation. So this is an overview of where we are at this point of TDM research in psoriasis. And I think Ghent group is one of the groups that is doing the research in TDM. Also a group by Professor Catherine Smith in the UK doing a lot of TDM research. And this is an overview of where we are per biologic. So for adalimumab, we have developed a therapeutic window. For istiquinumab, we have an early cutoff concentration that can distinguish optimal from suboptimal responders. And for secukinumab, guselkumab, and ixekizumab, we have found in steady state, so in treatment maintenance phase, cutoffs that can distinguish non-responders from or suboptimal responders from optimal responders. And we are still doing research for the others, as risankizumab, tilakizumab, and brodalumab. So we're still continuing our research, and these treatment measurements were mostly done by the Catholic University of Leuven by in-house developed assays. So, and Jurij also mentioned the model-informed precision dosing. So this is the future, I think, for us as well. So TDM will help us with dose escalation, dose de-escalation, but it cannot tell how precisely we have to change dose. So we have to work to the model and perform precision dosing to really individualize dosing regimens of patients. So pulling every information in one program and then telling the patient how he has to and when he has to administrate his injections. So I guess I'm at the end of my presentation. So if there are any questions, please feel free to ask.
You're muted,
Elisabet, you're muted.
Thank you
I'm
for
unmuted
letting
again.
me know. Thank you very much, Lisa, for an excellent presentation, and also thank you, Jurij, for your presentation. So we do have some time for some questions in the Q&A. So maybe I can ask while we're waiting for you to post your questions. So it's quite intriguing to see the number of new chemical entities that are entering these fields. So I was curious about your visions for the future. Do you think that this will be continuing on expanding the number of drugs in this field, or have we reached sort of a maximum number of new entities here?
Maybe I can start here. So I think it's the pipeline at the moment is still quite rich, although we are aware of challenges of actually recruiting that many patients, because we sometimes have like projections, simulations of how many patients with IBD would you need in the world, and of course acknowledging that not all of the patients fit into trials. So that's perhaps one of the challenges on the mid to long term. So making sure that patients in daily clinical practice actually match the patients who are included in trials.
Thank you. We do also have a question from Denis. Maybe you want to post your question yourself. Then you can unmute.
Yes, it's a question because we have been talking about dermatology and gastroenterology, and we're in rheumatic disease. We have an autoantibody to characterize and to diagnose our patients. So I was wondering if there is any research to identify autoantibodies as we have in rheumatoid arthritis, lupus, ANCA-associated vasculitis. So this is my question.
Maybe I can let Lisa go first in this one.
Just to comment some things. The question is basically because we target B cells in rheumatic disease and the disease I mentioned, which is not the case in Crohn's disease and ulcerative colitis and psoriasis. So I was wondering, is it because is there any attempt to any strategy to target B cells in your disease you are treating? So
the evidence for the presence of autoantibodies in IBD is tenuous at the best. There's been quite some effort directed to this, and there is some evidence of antibodies against a particular muscle type in the colonic wall, which can be observed in ulcerative colitis, but it's not been confirmed universally. And speaking to the hypothesis around B cells, so at least to my understanding, the classic anti-B cell agent rituximab, it failed in inflammatory bowel disease. The trial failed. It was not effective in our diseases.
Thank you.
I think I also had a question. Oh, I see George has a question, I think. Please go ahead.
Yes, you think right, Erwin. But I think I would like to go through some thank you messages first. So in my capacity of being the working group 5 leader in ENOTTA, I would like first of all to thank you, Erwin and Elisabet, for coordinating the webinar series. Also to thank Marlene for hosting the first webinar on Zoom. And last but not least, to thank the speakers, the two speakers, that they really kicked off very nicely the webinar series. My second point is, if you, Erwin and Elisabet, if you agree with me, I would like to encourage the participants to turn on the cameras actually, and to ask their questions individually rather than the chat box. This will also give us a sense of community and will bring us a little bit closer even if we are online. And now, as a third point, going into my question, which is mostly going towards the first part of the webinar. So for the first speaker, you mentioned the inter-individual variability. And if I got this right, it was a graph based on weight, basically, on body mass. Would you have any information on such variability on the basis of biological sex and ethnicity? Because, for example, Lisa mentioned in terms of prevalence, though, that there is a kind of an equal distribution between male and female individuals. But what do we know in terms of responses there on the basis of sex and ethnicity? Thank you.
So this was, perhaps suboptimally chosen plots, because the fact of weight, it was just an illustration for 3 different kinds of weight-based patients. So the main factors, at least in IBD, talking about monoclonal antibodies rather than small molecules, it's usually weight, albumin, and some sort of proxy of disease activity. Admittedly, the sex-related differences didn't pan out for monoclonal antibodies. Perhaps also due to the fact that analytically this is somehow concealed by differences in weight. On the other hand, what you mentioned about ethnicity is really important, alluding to my previous point about patients being able to enter trials. There's also accumulating evidence that, non-white ethnicities are underrepresented substantially in trials. So the fair answer is the data are deficient in this respect, and perhaps even more than for monoclonals, which are proteins, antibodies circulating around, the sex-based and ethnicity-based differences could come into play for small molecules, those metabolized in the liver, so cytochromes, polymorphisms. So there's more potential for differences in this respect, but further research needed.
Yes, and I think I can continue for psoriasis. So we also do not see differences in gender for as far as clinical response, but also the serum trough levels. So we have studied this. And secondly, so for psoriasis, we already have 2 biologics where we have a weight-based dosing regimen. So this is for ustekinumab and for tilrakizumab. So patients with either, I think it's 90 kilos or 100 kilos, they have a double dosed within the same time interval. So this is 2. And then thirdly, of other factors that might influence either the serum trough levels or the clinical response, the most important one is also for us the weight or BMI. So we see in patients with higher weight or high body mass index, we have lower serum TREF levels and a worse clinical response, but not for all biologics. So this is an important detail. And this also needs to be, is needed for further exploration, because our data was, well, we have really good data, but it's still small sample size. So we have to validate this in the bigger cohort. But sex was not, gender was not a cofactor of clinical response.
Okay, so if anyone has a question, please raise your hands. If you want, you can share that, or if you want to do it anonymously, feel free to drop it in the chat box. Might have also one small question. So the therapeutic armamentarium is growing and there's more and more drugs. And what I understood is that still, at least in IBD, we have this therapeutic ceiling that there's many patients that cannot be treated. What about combining monoclonal antibodies, 2 or 3 antibodies with different therapeutic targets? Is that something that is?
Yeah, this is indeed an interesting avenue, which is just beginning to be walked along in IBD. So we should here again distinguish clinical practice from trials, because in clinical practice, the combinations of monoclonals, or indeed combinations of monoclonal plus a small molecule, were usually employed, well, of course, after thorough discussion with the patients, potential risks involved, the fact that it's off-label in very refractory patients where everything has been tried, didn't work. They sort of developed some response to one drug, but wasn't fully they weren't fully in remission. Or perhaps what I didn't mention before, the presence of extraintestinal manifestations. So inflammatory bowel disease is perhaps a misnomer, because it's actually systemic. It can affect a multitude of organ systems, notably joints and skin, to mention just 2. And in some patients, a certain drug got the intestine under control, but didn't get the other organs under control. So these were also a subset of patients where we sometimes consider double treatment with more than one advanced therapy. For the moment, in trials, of course, this is understandable. It was a proof of concept trial combining guselkumab, an anti-interleukin 23 drug, and golimumab, an anti-TNF drug. In this phase 2 proof of concept trial, it was tested, and actually in patients with the very beginning of their ulcerative colitis. They haven't tried any biologics. Their disease has just begun. So admittedly, this is at the completely opposite spectrum of patients where you'd consider using double therapy in clinical practice. So for these patients, the trial patients with early disease, it indeed showed that guselkumab plus golimumab was better compared to either drug in monotherapy, but we're kind of still trying to make sense of how this translates to these more refractory patients. Of course, noting that guselkumab is not yet approved as monotherapy for ulcerative colitis, and that golimumab is, well, you know this just as well as I do, Erwin, possibly not the strongest drug for ulcerative colitis that we have in our armamentarium.
Mm-hmm. It's interesting. And then, do you know how these combinations, when they are studied at least, how these combinations are selected? Because I assume that pharmaceutical company A is not interested in testing a combination of their own drug with a drug of another company. Who is taking the lead there?
Yeah, admittedly, I'm not familiar with the behind-the-scenes developments here. Of course, this both guselkumab and golimumab were developed by the same sponsor, so that was perhaps one aspect of the motivation for choosing this particular combination. That being said, nonetheless, there was some preclinical research into the gene expression pathways, and there was also some rationale for combining these two in ulcerative colitis, although probably the fact that they had both drugs available in the house was perhaps more of the motivation. Not sure.
Okay. Thank you very much. I think I just see that we it's 6 o'clock here, means 1 hour. I don't think we should step over our time unless there are very urgent questions, and I see it in Jurij hand. So please, Jurij.
Yes, I forgot to thank one person. That's our science communication coordinator, Mehmet Etik, who has been taking care of all the posting and marketing, let's say, and announcements of the webinar series. So thank you, Mehmet.
Okay, wonderful. Thank you all. Thank you, Jurij. Thank you, all the people that you thanked. And especially thank you to Jurij and Lisa for starting the webinar series. Thank you very much. We have our next webinar in a month. All the information is on the website. You will see it coming by on the social media. So feel free to join that time as well. Thank you all. Have a nice evening or rest of your day, and hopefully see you in a month.
Thank you. Bye.
Thank you.
Thank you.
Have a nice
Bye
evening,
bye.
everyone. Bye bye.
Thank
Bye-bye.
you. Bye.
Bye.